So good morning all. We all know that protozoal infections are very common. There are several protozoal infections which can affect the human health and precipitate as diseases. So you have seen that some diseases which are caused by bacteria, diseases which are caused by virus, diseases which are caused by fungus, etc. Similarly, protozoal diseases are also very common. I hope you can enumerate some of the common protozoal infections. So for example, like amoebiasis, giardiasis. Similarly, malaria is another protozoal disease which is very common in several Indian states. Especially, malaria is very common in South Canara districts of Karnataka, then Bihar, Orissa, Jharkhand, etc. So, understanding the concept of antimalarial drugs is very important, and unless the life cycle of Plasmodium or the parasite is discussed, it is difficult to understand the concept of the treatment of malaria. All right. So, in this class, we're going to discuss about antimalarial drugs. Welcome to my class. I'm Dr. Mirshad, Associate Professor of Pharmacology. All right. So before we start the antimalarial drugs, let's talk about life cycle of the malarial parasites. Here you can see the life cycle in a single slide and see the which mosquito is responsible for the malarial infection. Which you know several mosquitoes, Aedes, and okay, and is it Aedes? Which mosquito is responsible? I hope you know which mosquito is responsible. So the female Anopheles mosquito is a reservoir which the biting of the mosquito causes entering of the sporozoites, the form of pathogen or the parasite. It's called sporozoites, and that can directly enter into the liver, and in the liver it undergo some three different life cycle, or I mean life cycle means consequences. Some parasites like some there are different strains of malarial parasites. We'll be discussing that later. So this parasites remain in dormant state. It is called hypnozoites. Hypnotics, you know, what is the meaning of the term hypnotics? So hypnozoites is a dormant form which will not undergo any division, multiplication, or any life cycle, which will be remaining in the liver as hypnozoites, and some of them directly enter into the blood and is called merozoites. So in the blood, it causes lysis of the RBCs, and the pathogen utilize the heme for its nutrient purpose, and that is the major reason for the hemolysis during the malarial infection. So what happened? This will undergo several life cycle, asexual life cycle, and multiplication of the pathogens or the parasites takes place. And meanwhile, a fraction may develop as gametozoites, and these gametocytes can be taken by a mosquito when a mosquito bite to the person, the carrier or the reservoir, so that will be extended to the next person. So this is how the life cycle takes place. So some terms you have come across now includes sporozoites, merozoites, hypnozoites. The active life cycle form is called merozoites, which takes place in the blood circulation and causes hemolysis. And of course, the other symptoms, of course, fever and all those can be manifested. And another term which you should remember is gametozoites. So please remember, and please remember this terminologies. And of course, we have various group of drugs which are targeted to different life cycle stages of the life cycle of the parasites. So we'll be discussing in detail about that. Again, this is what the extensive part of what we have studied. Okay, the Sishodogani, the merozoites, hypnozoites, all these uh, life cycle stages are discussed in detail under this. Now, let's see the classification of antimalarial drugs based on parasite developmental stage targeted. So, you can classify the drugs into various categories based on different aspects of the mechanism. Now, you can see this drugs which acting on the sporozoites, drugs which acting on the hypnozoites, that is the liver stage, and blood stage, the gametocytes and the merozoites. Okay, merozoites. So these are the drugs. You can see the drugs, various drugs over here: artesunate, chloroquine, mefloquine. Whenever you hear about malaria, the prototype of the drugs which come to your mind is chloroquine. Of course, there are many other drugs, but chloroquine is the very old drug which is being used, and now it is still used for the various infection. Various type of, there are different types of infections. We're discussing all those. And mechanism based on, classification based on the mechanism of action. Inhibitors of heme metabolism. So heme can be utilized, and human heme, the host cell heme can be utilized for the nutrient purpose by the parasite. So this metabolism of the heme can be inhibited by a group of drugs led by chloroquine, quinine and quinidine, both are analogs which are actually alkaloids derived from cinchona bark. Then a newer group of drugs, artemisinin derivatives, which includes artesunate, artemether, and dihydroartemisinin. In fact, artemisinin-based multi-drug therapy is newly emerged drug therapy against chloroquine-resistant strains. Then electron transport chain. Of course, electron transport chain is an inevitable part, or the vital part of the cell metabolism, cell metabolic rate. Primatune and atropine are the two drugs which interact with the electron transport chain. Protein synthesis. Of course, you have seen several drugs, antibiotics like tetracycline, chloramphenicol, aminoglycosates, which interact with the protein synthesis. Similarly, some of the antimicrobials, in fact, these are the same drug which has got anti-malarial activities too, includes doxycycline, tetracyclines, and clindamycin. All the pharmacological aspects of these drugs have been discussed elsewhere earlier. Now, folate metabolism, again, these group of drugs are also discussed in detail under sulfur drugs. Sulfaroxine, pyrimethamine combination, then sulfanaxine, pyrimethamine, proguanil, these are the other components. The combination of sulfamethoxazole and trimethoprim, you have seen that it is called cotrimoxazole. Now the similar combination, but different molecules from sulfur drugs, and pyrimethamine is also exclusively used for the treatment of malaria, right? Now, after the mechanism of action based classification, let's move on to the chemical classification. So, this is not very, like, you don't have to remember each chemical group. So, I'm just going to the next slide, and just you have a look on this. All these are the familiar drugs when you talk about the antimalarial agents. Of course, you don't have to remember which is cinchona alkaloids. I have already told you quinine, cinchona alkaloids, bigonates, proguanil. Okay, so I don't want you to remember this chemical name. Tetracyclines, including doxycycline. Okay, amino alcohols, halofandrin, lumefantrine, these are newer drugs. Then managed-based pyronadine, atropine was there. Now again, this is not very clear or very significant part in pharmacology. Of course, it's on. You have seen the basic endemic areas. Now you can see the India here, and in India, the green shaded shows we have predominantly the chloroquine-resistant strain of the malarial parasites. Okay, and the sub-Saharan African areas. Okay, and only in certain places like Latin American, Argentina, and North America and Mexico, all these places, you can see the chloroquine sensitive. Okay, and the white shaded portion are relatively non-endemic to malaria infection. Uh, Now I have told you about the heme metabolism. So how this taken place here? Let's see now. You can see here the yellow enlarged portion of the RBC. You can see the hemoglobin, which is contain amino acids and heme. Okay, so this heme is converted into hemozoin. Okay, which is by the parasites. The hemozoin can be utilized by parasites. Now, chloroquine inhibit this process. Chloroquine inhibit the conversion of the heme into hemozoin. So this actually takes place inside the vacuole of food vacuole of the plasmodium parasites. So this process, the conversion of heme into hemozoin, will be inhibited by the drugs like chloroquine and mefloquine, etc. So this is what I have told you. Mechanism under the drugs which inhibit the heme metabolism. Okay. Now the another one is the mitochondrial electron transport chain. So you know that the electron transport chain takes place in almost all the cells, including eukaryotic and prokaryotic cells. And here, when you consider the parasite cells, again there also the same process takes place. So some drugs, atovaquone, which can interfere even with the primaquine, even can interfere with the processing of the cascade pathway of the electron transport chain. So of course the electron transport chain is an inevitable or vital reaction takes place in a cell, and that can be inhibited by certain drugs. Alright, so this is what I wanted to tell you. Now artemisinin. What is the mechanism of actions of artemisinin? I told you this is actually again here it is interacting the ion mechanism, artemisinin free radical, which interact with the heme metabolism. Again, heme metabolism will be inhibited. Now let's talk about the individual drugs. So what I have introduced about the mechanism, base and other basis of the classification. Then we have discussed the mechanism of actions, including heme metabolism interacting drugs, electron transport chain interacting drugs, and finally the drugs which interact with the heme metabolism like artemisinin derivatives. So chloroquine, which is a mechanism we have already discussed. Chloroquine mechanism is already discussed, which interact with the conversion of heme into hemozoin. Prophylaxis and what are the uses? Prophylaxis and treatment in areas without resistant P. falciparum, vivax, oval malaria. So before that, I wanted to tell you there are 4 strains of malarial parasites. One is Plasmodium falciparum, here I have mentioned. Second one, Plasmodium vivax, and third one is Plasmodium ovale, and fourth one is Plasmodium malaria. Okay, there are 4 strains: Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum. Okay, so these strains, as far as the chloroquine is concerned, it is used in prophylaxis and treatment of areas without resistant. Wherever, evideano falciparum malaria, chloroquine sensitive strains are there, prophylaxis treatment and use. Adverse effects include GI, gastrointestinal distress, rash, headache, auditory dysfunction, and retinal dysfunction. Of course, see, when the chloroquine high dose is used for a long period, as noted in the treatment of malaria, this one, rheumatoid arthritis, as drug modifying anti-rheumatoid drug can be used. It can cause deposition in the retina, and retinal opacity can be manifested, but it is usually not seen in the treatment of malaria because it is always a short term. Okay. Mefloquine is the next one. Again, the mechanism is the same as chloroquine. And what are the uses? Prophylaxis and treatment in areas with resistant P. falciparum. Okay. Resistant P. falciparum means chloroquine resistant. So wherever the chloroquine-resistant P. falciparum malaria is predominant, where you can use mefloquine. Adverse effects include GI disturbances, including diarrhea, vomiting, nausea, rash, headache, cardiac conduction defects, and neurologic symptoms. Especially this is observed with the high doses. The neurological symptoms are evident only with the very high doses. Quinine is actually an alkaloid obtained from cinchona bark. The congeners of quinine, including quinidine, both are used very frequently. It can be used in treatment of certain arrhythmias that you will discuss when we talk about the cardiovascular diseases, especially treatment of arrhythmia. And this is actually quinine, and quinidine is used in multi-drug resistant malaria, where malarial parasites are resistant to mefloquine and chloroquine. In most cases of quinine, it is used together with the doxycycline or clindamycin or an antifoliate, like but we have seen that pyrimethamine or sulfur drugs. IV quinidine is used in severe infections, especially the severe brain abscess due to malarial infection, where oral quinine is not sufficient or cannot be taken. Synchronism is a group of conditions which includes the swelling of the lids, chills, fever, etc. Then hemolysis in G6PD deficiency, we have seen that. What is the importance of G6PD, glucose 6-phosphate dehydrogenase enzyme deficiency, and how it is related to the hemolysis or oxidative stress. Black water fever are the other adverse effects associated with the quinine. Now, let's talk about primaquine. This is actually, primaquine is not used for the prophylaxis of malaria or treatment of malaria. It is only used for the radical cure, eradication of liver stages. So I have told you there is a possibility of some strains, which strains Plasmodium vivax and ovale, which remain in the liver as hypnozoites, which never come to the bloodstream. So when you treat the malarial infections, especially the blood forms, merozoites, merozoites can be completely eradicated by the sensitive drugs. But the problem, these drugs may not target the hypnozoites, which is in the liver. So what happened? After complete cure, these hypnozoites may come into the bloodstream again. So that may cause relapse. So if the infection is due to vivax, especially vivax, even in the complete cure of the disease, there is a possibility of relapse due to the accumulation or dormancy of the dormant stage survival of the pathogens in the liver. So primaquine can target these hepatic stages. So it is useful for the radical cure of malaria and eradication of liver stages. Adverse effects include GI distress, hemolysis in G6PD deficiency, methemoglobinemia. You know what is methemoglobinemia. And therefore, see the what exactly I wanted to tell you. Primaquine is contraindicated in pregnancy because it is not due to the teratogenicity, because it is safer. But we don't know whether fetus has got G6PD deficiency. So in order to be safer side, we will usually don't undertake the treatment with primaquine during pregnancy. Antifolates we have pyrimethamine, then we have sulfadoxine, not sulfadazine, sulfadoxine. So it is used for the prophylaxis and treatment of multi-drug resistant P. falciparum malaria. Sulfadoxine plus pyrimethamine or sulfaline pyrimethamine, proguanil, these are the drugs used under antifolates. All these drugs inhibit the folic acid synthesis from the PABA. You have seen the metabolic pathway and sequential blockage. GI distress, renal dysfunction, especially the crystallization of these drugs in the renal tissues are a problem. Hemolysis, folate deficiency is very rare, though it is specific to the parasites, folate, but a large quantity for a long period may have a folate deficiency in human health. Atrovactin and proguanil combination, again this is also antifolate and atrovactin combination. Prophylaxis and treatment of multi-drug resistant P. falciparum malaria. So multi-drug resistant strain of P. falciparum malaria, Plasmodium falciparum is usually shows resistance to many drugs, including primarily chloroquine. Even it can show resistance to mefloquine or quinine, etc. So that there the combination may be useful. Adverse effects include GI distress, headache, rash, hemolysis, folate deficiency. Then we discuss about the relatively newer group of drugs. Of course, these are a very effective group of drugs having very high potential effects against chloroquine-resistant malaria. There are three members: artesunate, artemether, dihydroartemisinin. These are the members of the group. Treatment of multi-drug resistant malaria, especially cerebral malaria. You have seen injections of quinidine or quinine may be useful for the severe state of cerebral malaria, but newer artemisinin derivatives are also very effective. GI distress is the most important adverse effects. Oral artesunate monotherapy is banned in India because of their fear of causing rapid development of tolerance. So tolerance is very common. So now so we have discussed the uses of each drugs. We have discussed the use of chloroquine. Chloroquine is highly useful for the treatment and prophylaxis of any strains if it is sensitive to chloroquine. Prophylaxis. When do you want prophylaxis? That we'll discuss later. And treatment. Of course, the patient showing clinical manifestations of malaria. Then we have discussed about the mefloquine, quinine derivatives, then drugs like artemisinin derivatives or folate, antifolate, atrovactine, etc., etc. Now let's discuss one by one. Treatment of uncomplicated Plasmodium falciparum. Treatment of uncomplicated Plasmodium falciparum malaria. So it's a common malarial infection. How do you treat? Artemisinin combination therapy is the drug of choice for all confirmed cases of uncomplicated Plasmodium falciparum. Now, why artemisinin combination? Because in India, 99% of the Plasmodium falciparum is resistant to chloroquine. So you cannot use chloroquine because most 99. You have seen the endemic areas where India was denoted as a green shaded portion, which indicates that the strain is resistant to, or the falciparum is mainly in India we have falciparum. Very common infection is Plasmodium falciparum. So most of the strains of falciparum is resistant to chloroquine. So if the complication, if the infection is due to falciparum, which is uncomplicated, there is no complication, there is no cerebral infection or the central infection, definitely you can go for artemisinin combination therapy. Okay. This should be combined with the Primaquine, 45 milligram on day 2. The artemisinin combination therapy recommended in the national program of India is artesunate plus sulfadoxine and pyrimethamine. So this is the combination based. It's called the artemisinin based combination therapy. So you may it's very important as far as your examination point of view as well as the as a clinician. It is both are very important. So please remember artesunate based drug combination includes sulfadoxine and pyrimethamine. So we continue the short plasma TF of artemisinin and its derivatives results in treatment failure rates when artemisinins are used as monotherapy. So there is a chance for therapeutic failure, especially due to its very short half-life. Combination of artemisinin derivative with a longer-lasting partner, we are seeing adofrantin or tetracycline-based drugs, a very promising group. Okay. Current artemisinin-based combination therapy regimes that are well tolerated in adults and children, more than 5 kg, includes artesunate, sulfadoxine, pyrimethamine combinations. So these are the examples of commonly used ACT. Artemether, lumefantrine, or halofrantin, artesunate, mefloquine, artesunate, amodiaquine, dihydroartemisinin and piperacin and also artesunate pyronidine. So these are the artemisinin combination therapy with the different examples, different rational and combination. Treatment of uncomplicated Plasmodium vivax. So we have been talking about the treatment of Plasmodium falciparum. Plasmodium falciparum. Because in India, Plasmodium falciparum is chloroquine is resistant to Plasmodium falciparum. So whether it is complicated or uncomplicated, ruled out. The possibility of malaria, chloroquine is ruled out because chloroquine is resistant to most of the Indian strains of falciparum. So that's all. Like we have discussed about the artemisinin combination therapy there. Now let's move on to the next step. It's the treatment of uncomplicated Plasmodium vivax. So if it is the infection is due to vivax, you can use chloroquine there because vivax is highly sensitive to chloroquine. You don't have to think about any other drugs. Chloroquine is the drug of choice for Plasmodium vivax. Not just for the treatment, it is also effective drug for the prophylaxis. It's given at a dose of 600 milligram base. This is a chloroquine base tablet is available 600 milligram on day 1 and day 2 and 300 milligram on day 3. So day 1 600 milligram, repeat the same dose on day 2 and go for half of the dose on the day 3. So the 3 doses. This is how the treatment of uncomplicated vivax infection. Plus, see, it is due to vivax. So vivax have a chances to accumulate in the liver as hypnozoids. So if you're targeting only the blood strain of vivax, there is a possibility of relapse. So you have to target the hypnozoids, and it's called radical cure. You can use 15 milligram per day for 14 days to prevent relapse, and it is called radical therapy, radical cure, to offer radical cure. Primaquine is contraindicated in G6PD deficiency cases, infants and pregnant women, because it can cause hemolytic anemia. Now the third one, treatment of uncomplicated Plasmodium falciparum cases in pregnancy. See, the first one I told you, uncomplicated Plasmodium falciparum. But in normal cases, now we are talking about in pregnancy. Quinine. So there, of course, chloroquine cannot be used. So the safe artemisinin derivatives are not recommended in pregnancy. So you can go for quinine. Drug of choice is quinine. First trimester in a dose of 10 milligram per kg for 8 hourly, orally for 7 days. The second and third trimester, ACT is recommended. Okay. So during the second and third trimesters, where the organs are developed, artemisinin-based therapy may be recommended. So it can go for artemisinin. So the third one was treatment of uncomplicated Plasmodium falciparum during pregnancy. And the fourth one, uncomplicated Plasmodium vivax cases in pregnancy. If it is vivax in pregnancy. See, I told you, vivax in normally chloroquine was. Now, chloroquine can be used here. Chloroquine is safer in pregnancy. And of course, vivax is sensitive to chloroquine. So, no doubt, you can use chloroquine. In any trimester, chloroquine is choice. Now, the next one is severe Plasmodium falciparum. There are two things. One is, it is severe cases. It can be included cerebral malaria, and also this is resistant to chloroquine, because I told you Plasmodium falciparum is resistant to chloroquine. So parental artemisinin derivatives or quinine should be promptly given to prevent deaths. So both are sensitive. Even if it is uncomplicated cases, oral artemisinin derivatives are available. Whereas in complicated cases, parenteral administrations are possible. Intravenous preparations are preferred. Artesunate is the drug of choice in severe Plasmodium falciparum infection. It should be given at a dose of 2.4 milligram per kg IV on admission. As soon as the admission, then 12 hours and 24 hours. So 3 doses. Day 1, After 12 hours in the evening, if it is in the morning, give artemisinin, then repeat after 12 hours, maybe 6 p.m. If it is first dose is given at 6 a.m., 6 p.m. Then next day 6 p.m. So these are the 3 doses are recommended for the cerebral falciparum cases. After that, once daily till the patient takes orally or 7 days or for 7 days. Okay. Okay. They should get full course of ACT orally for 3 days. In case of severe Plasmodium falciparum, quinine is an acceptable alternative to artemisinin. Next is the treatment of severe Plasmodium falciparum cases in pregnancy. Okay. So this is about the severe case. In the previous slide, we discussed about the severe case of Plasmodium falciparum in normal healthy person. Now, regarding pregnancy, you know that the first trimester where the artemisinin cannot be given, it is contraindicated. Then you can go for quinine in the first trimester. If it is not avoidable, parental artemisinin derivatives can be given to save the life of the mother, but it is not very much recommended. But third trimester, second and third trimester, you can go for the artemisinin derivatives. So this is the same way how you treat the severe case of Plasmodium falciparum in normal cases. The same way, but it has to be given parentally. Now, chemoprophylaxis. What is a chemoprophylaxis? Usually, if a person is desired to visit an endemic area, to a malarial endemic area, okay, so there you may require treatment, prophylaxis, causal prophylaxis, short term. If a visit is for less than 6 weeks, the person is going to stay a place where well known to endemic to malaria. So, but the person is going to stay for less than 6 weeks. So we can prevent the infection by giving 100 milligram per day of doxycycline. That has to be started 2 days before the journey. See, we are planning to visit on 3rd of June. So you should start on first day. Day 1, that is the 1st of June, 2nd of June, and continue. Okay, continue for 4 weeks after leaving a malaria endemic area. So you are staying 6 weeks there. Okay, so start 2 days before the commencement of journey and take every day 100 milligram as long as you stay there. If it is 2 weeks, take completely for 2 weeks, then return and continue for 4 weeks. 1 month after you return back to the normal, your native, you have to continue for 4 weeks. Okay, so this is how the doxycycline is used as chemoprophylaxis. It's not recommended for pregnant and lactating women and children below 8 years of age. Okay. Long term, more than 6 weeks is considered as if usually it is possible where employment related or army professionals and all. So if you are visiting a place which is well known to malarial endemic area, usually you can give weekly 250 milligram. അതായത് ആഴ്ചയിൽ ഒരു ദിവസം മെഫ്ലോക്വിൻ you can give. But you have to start 2 weeks. നമ്മൾ 15-ാം തീയതിയാണ് പോകുന്നതെങ്കിൽ 1-ാം തീയതി സ്റ്റാർട്ട് ചെയ്യാം, 7-ാം തീയതി കൊടുക്കാം, പിന്നെ every weekly once as long as you stay there, and the same way continue the dose every week for a period of 4 weeks. For 4 ഡോസും കൂടി നിങ്ങൾ തിരിച്ചു വന്നതിന് ശേഷം സ്റ്റാർട്ട് ചെയ്യണം, കണ്ടിന്യൂ ചെയ്യണം and finish it off. This is how the long term, as long as you stay there, weekly take 250 milligram of mefloquine. It is characterized in case with a history of convulsions, neuropsychiatric problems and cardiac conditions. So this is about the treatment. So with this we have finished treatment of malaria. Thank you. So as a recap, let's talk about the introduction. I told you the stages of life cycle of malaria. There some terminologies like hypnozoites, sporozoites, gametozoites, merozoites, etc. And the drug And I wanted to tell you, and in your textbook, you can see this tissue C-chondrocytes, okay, erythrocytocytes, the two categories. The tissue C-chondrocytes are mainly those drugs which affect the liver strains. And erythrocytocytes are those agents which mainly produce the clinical cure, which acts in the blood form. Okay, so these two terminologies we missed, and I think there will be a classification: tissue C-chondrocytes and erythrocytocytes. So tissue C-chondrocytes are mainly targeting the liver forms, and erythrocytocytes are the blood forms. That's one more is gametocytocytes. Third one. So gametes. Primacune is mefloquine are the major examples for those categories. Then after that, we have classified the drugs based on mechanism, based on the chemical, strain based on the targets, etc. Then we have discussed the mechanism of each group of drugs, mainly the metabolism inhibition, electron transport chain, antifolates, then protein synthesis inhibitors, etc. Later, we have discussed the individual drugs uses and its adverse effects, includes chloroquine, mefloquine, etc. And before that, I repeat, there are four strains: Plasmodium vivax, ovale, falciparum, okay, and then malaria. So these are the four strains, and each strains are having distinct life cycle, because vivax and ovale is known to have the hypnozoites tissue cycles, and it is hypnozoites, and which is mainly responsible for the relapse. Okay. Second thing I wanted to tell you about, next is about the, so classification is over. Then we have discussed about the treatment. See, treatment includes the uncomplicated falciparum malaria, complicated falciparum malaria in pregnancy, then vivax and ovale complicated cases, then vivax and ovale infection normal and pregnancy, then chemoprophylaxis for short term and long term. Okay, so this is what we have discussed under the treatment of malaria. So I hope you understood. You could follow the classes well. If you have any doubt after listening the class, and you can ask me anytime, or you can raise the question in the WhatsApp group, or you can ping me personally. All right. So this is what I wanted to discuss under the topic malaria. Now, after listening this, please answer these two questions. One is, what are the other uses of chloroquine? What are the other uses of chloroquine, which I have at least one or two uses, which I have discussed during the discussion part of chloroquine. So two other indications other than malaria. That's a question number one. And question number two, which are the protein synthesis inhibitors we have discussed? Protein synthesis inhibitors, which are used elsewhere, can be used in malaria too. So these are the two questions. Please answer as a comment in comment box. Once you answer this question in comment box only, you will be getting attendance. Okay? Thank you. Thank you for your patience. Have a nice day. We'll call it a day.